India Life.
Good evening, one and all. I welcome you all for 30th season of IIRSI Online Video Symposium. When the going gets tough, the tough get going. And today we have this session with YOSI, Young Ophthalmologist Society of India, with the theme, YOS Learning from Their Mistakes. I believe that one should always treat mistakes as opportunities for learning, because mistakes are the stepping stone which make us a better surgeon. I'd like to thank entire office bearer of YOSI for this collaboration. And I'd like to thank our esteemed panelist, Dr. Krishna Prasad from Hubli, Dr. Gopal Raju from Visakhapatnam, Dr. Suvira Jain from Mumbai, to be with us, along with the other panelists from YOSI, Dr. Sonal Kalia, Dr. Divakant, and Dr. Nikunj. And today, I have with me my co-moderators, Dr. Vardhman Kakriya and Dr. Zain. So I'll request Dr. Vardhman to explain the format of the symposium.
Yeah. Thank you, Dr. Harshul, and welcome to one and all. I think there is probably echo somebody else. Somebody's using two systems to check it. So welcome all from IIRSI, and this session is going to be very unique because this is with our friends with Young Ophthalmologist Society of India. And as we just discussed, this is the 30th season for the growing stuff that's going. And we are going to learn from our young friends about the possible, let's say, difficulties that one can have in the surgeries and how to overcome them. This session has a format of having no didactic talks. So basically, every presenter is going to showcase a 4-minute video, which is going to be of their surgical challenges. And meanwhile, our panelists can stop their videos and they can ask them pertinent questions. They can discuss how that particular step could have been done in better way, or even narrate how the plan has been executed very well. So we all believe that we are going to take away a lot of learning pearls. And we welcome all our expert panelists and also our YOSI friends for this symposium. And here we begin. Thank you.
Dr. Zain?
Yeah, good evening, everyone. Thank you, Harshul sir, Vardhaman sir, for including me. And I'm very excited to be part of this collaboration between YOSI and IIRSI. And Vardhaman sir and Harshul sir have been hosting this very well since the last few times. Am I audible?
Yes, you are.
Okay. So basically this time with YOSI coming in, we hope through YOSI we can add a new dimension, because for young ophthalmologists, especially recording and studying your own surgical videos is something that is extremely important. And many times we see things are going wrong by studying your own videos. So these kind of sessions really help young ophthalmologists. It will encourage us to send more such videos. So over to you, Harshul sir, to introduce the panel.
Thank you, Zain. So let me introduce our first panelist, and that is none other than Dr. Krishna Prasad. We all know Dr. Krishna Prasad is teacher of teachers, and he has his students pan-India, all over India. They have trained, I think, thousands of students from M.M. Joshi Eye Institute in Hubli. And I had the fortune to be there many times doing live surgery and to conduct many sessions there. And it's an amazing institute they have, amazing environment they have, and amazing academics they have there. It's always a pleasure to have Dr. Krishna Prasad in our symposium. Welcome, Dr. Krishna Prasad.
Thank you. Thank you, everyone.
And then we have Vardhman. Dr. Suvira is there. Yes.
So then we have Dr. Suvira Jain. She's a very prolific cataract and refractive surgeon. I think especially that this session has YOSI is very relevant because Suvira is such a big figure when it comes to phaco training. She has trained more than 1,000 young ophthalmologists to learn their first phacos. She herself is a very prolific corneal transplant surgeon, so also has done more than 1,000 corneal transplants. She runs her own private setting, and as well as she has attachment with a high volume Bachuali Eye Hospital at Parel. And we welcome Suvira to have to be there with us in this symposium. So I'm sure that we are going to learn a lot from you.
Thank you. Thank you.
Then we have Dr. Gopal Raju, who is director at Vishaka Eye Hospital in Visakhapatnam. Dr. Gopal Raju is right now chairman, scientific committee of Andhra Pradesh Ophthalmic Society. He's a prolific cataract and refractive surgeon, and he's also past secretary and past president of Visakhapatnam Ophthalmic Association. And over and above that, he's a fantastic human being, a very pleasant personality, and a great teacher. We welcome you, Dr. Gopal Raju, and thanks for being there with us today. And now I'll request Zen to introduce panelists from the Young Ophthalmology Society of India. Zen?
Yes, thank you, sir. So from the YOSI group, we have with us Dr. Sonal Kalia, who we all know is the YOSI president. She's an assistant professor at SMS Medical College, Jaipur. She's the president of YOSI and an executive member of Jaipur Ophthalmic Society and Rajasthan Ophthalmic Society as well. Then we have Dr. Nikunj Tank, who's a cornea, cataract and refractive surgeon from SRJ Netralaya, Indore, and he himself is a very keen interest in surgical video recording as well, and teaching through surgical videos. So welcome, Dr. Nikunj. And then we have none other than Dr. Divakant Mishra, who is unfortunately not joined yet, but should be joining soon. He is the director of Swarjyoti Eye Hospital and currently the vice president of YOSI. And also Dr. Karan Bhatia, who's also going to be joining soon, who is the current secretary of YOSI. So, yeah, so all
Thank you
all
so
the
much.
YOSI members.
Thank you so much, Zen. And thanks, Dr. Sonal, president of YOSI, for collaborating with IIRSI and having this session. I'll request Dr. Sonal to just say a few words before we take the first presenter and we begin the show. Dr. Sonal.
Very good evening to everybody. I'm extremely grateful to Dr. Zain and Harshul sir for the kind introduction. And we are extremely thankful to IIRSI, who has always set benchmarks in techniques and videos. And today, YOSI is honored to have this association with IIRSI because they have, in this particular webinar, come up with this fun theme to have voting for the best videos. And the excellent panelists are going to guide, the IIRSI panelists are going to guide in the young ophthalmologists in learning from their mistakes. And at the end, it would be a fun competitive way when the voting would begin. So we are once again thankful to Harshul sir and entire team of IIRSI, Vardhaman sir, and the panelists who have joined us. So let the meticulous 3D section of the videos and the voting begin. Thank you very much.
Thank you, Sonal. So let's begin with the first presenter. And the first presenter is Dr. Aarti Heda. Dr. Aarti is consultant and anti-segment surgeon at NIO Pune, Maharashtra. She is qualified towards DNB, FICO, MRCS, FRCS, ICO. She has all the degrees which are possible in ophthalmology. She is academic in charge of Young Ophthalmology Society of India. She runs a webinar series Surfing the Anti-Segment under YOSI since May 2020. She is also national and international coordinator for International Society of Manual Small Incision and Cataract Surgeon. She is YO committee member of Pune Ophthalmic Society. And she's going to show one of her case today. And to discuss this case with her, I'll request Dr. Krishna Prasad and Dr. Sonal to discuss this case with Dr. Aarti. So, Dr. Aarti.
Thank you so much. Thank you so much, Harshul sir and Vardhaman sir, team IIRSI and team YOSI for this wonderful opportunity.
Just a minute, Aarti. Mr. Sunil, I'll request you to please mute everybody other than Dr. Aarti, please. Yeah, please.
Yeah, just don't mute me. So I always get the feeling of opening batsman when I'm presenting first, and because of my name, I'm generally the first presenter. So here we go with my video. So this 53-year-old gentleman presented with inferior iridodialysis and subluxated mature cataract. The plan was to do iridodialysis repair with cataract extraction with SFIOL. So after proper counseling and the consent, patient was taken up for surgery. The conjunctival peritomy was done and the bleeders were cauterized. The scleral tunnel was fashioned and the two scleral flaps were made at 3 and 9 o'clock position. The anterior chamber was then entered and a side port was fashioned. A 10-O proline double-arm needle was used for the iridodialysis repair. An attempt was made to break the synachium. So this is the unedited part of the video. I really had to struggle to break the synachium. And the root technique was used for the iridodialysis repair.
Dr. Aarti, can you pause your video? Okay. Dr. Krishna Prasad. So,
Yes.
what is your approach? Like to first do cataract surgery and then do iridodialysis repair, or to take care of the iridodialysis first? And because there is
Yeah, I was just planning. I was just thinking of interrupting her once she's going to finish this. The thing is,
so you can
I
stop
would have-
in between. We can
Okay,
just
sure.
discuss, yeah, in between a little bit.
Okay.
Yes.
My plan would be to actually take this iris away. See, now obviously you cannot do a phaco because you cannot get enough exposure to get a capsulotomy or to do a nuclear emulsification. And this particular strip of iris will be keep coming in between for our probe.
Yes.
So I would rather put an iris hook and take both of them away till the time
Yes.
I complete my cataract business. And later, probably I will be, it's much easier because you have more space in the anterior chamber. And in this case, you may probably damage the anterior capsule. You may not get a rhexis right. You may further, move the lens and maybe make the zonular disintegrity further worse. So my choice would be to take it away, complete the surgery and come back to the iris later.
Okay. Okay. Right.
I think Aarti, you can continue. Let's see.
Yeah, Aarti, continue. Yes.
So you can see the presence of vitreous in the anterior chamber. The subluxated cataract was then removed. And after the use of triamcinolone, the anterior vitrectomy was done. The scleral fixated IOL was then implanted. So again, the 10-O proline suture was used for the same. So these suture knots are very important, and one should take care that they are tight enough. Otherwise, in the post-operative period, you can get the wobbling of the lens. And while implanting the lens, the care has to be taken that the sutures are not entangled in the haptics. Otherwise, you will have to make the second attempt. The IOL was then placed. And the visco wash was done. The main root was then suture with 10-O nylon suture. And the conjunctiva was done. The case was concluded. Post-operatively, patient had vision of 6/9.
Okay.
He
Very
was,
nice.
what was the age of the patient? 52 years or 53 years?
53 years.
And it is a trauma, blunt trauma. How many years ago?
So it was like almost 15 years ago. He came for the other eye. And then I just convinced him that we can do something for this eye as well, because the B scan was normal.
Okay. Okay.
I
And
think maybe she had planned SFIL already and she was not worried about rupturing the anterior
no,
capsule.
that's
No,
what.
so
I mean,
yes.
did you anytime consider preserving the bag since he's 53 and it's not like a pseudo exfoliation nor like a senile zonular weakness? Since he's 53 and a traumatic cataracts normally do not have a extensive zonulopathy. So did you anytime consider any options of retaining the bag and putting a normal PCI wool, maybe in the sulcus?
But since there was vitreous in the anterior chamber, I was really not confident of just retaining the bag. And I thought it will be easy for me to remove the whole cataract as it is and then do the SFIOL. So I don't know whether phaco could have been attempted in this case. I really don't know whether phaco could have been attempted in this case.
No, doing phaco is one part. Retaining the bag is another part. So basically, you had presumed that you will not be able to retain the bag. You went in with the idea. That's fine. If you have a plan for any surgery, if you have a good plan and if you execute it, I think the outcome is really good. I should really congratulate you for a very wonderful, a very atraumatic surgery and taking care of every step. I mean, all the details of the case, including iris management, as well as taking putting the lens in the right place. But this was 53-year-old. Obviously, the cataract is not very hard, and it's a traumatic zonular dialysis. So maybe after managing the vitreous in the anterior chamber, if you can probably put a capsular hook and try to create an artificial zonules for the time being, you could have probably, I mean, there is a possibility of managing this through phacoemulsification also. And also then probably putting an AMAT segment to create the to create a stable bag and maybe put a lens in the sulcus and capture it in the rexis. So this is one of the options, but all said and done, the patient wants good vision, clear cornea and an atraumatic surgery. Whichever way, whatever is the technique of choice, I think can still achieve the same result. Congratulations once again for a very wonderful experience.
Thank you,
Dr. Sonal?
Yeah, actually, that's what I was trying to say, that, we can all say that why didn't you use a label with an IMH segment and other things, but all one should use the method which one feels most comfortable in and give the best results in our hands, rather than, and as such, as an afterthought, we all can say a lot of things, but I think Aarti did a very, very wonderful job, and congratulations for successfully managing this case.
Thank you so much, Dr. Sonal.
Anything to add, Dr. Suvira or Dr. Gopal Raju, quickly? Because the lens was lastly subluxated and then vitreous in the AC. Anything attempting like phaco or retaining the bag may not give much advantage. Like what she has done is a very good plan, cleaning the anterior segment free of vitreous and then fixing the lens to the best plan. Right.
Thank you so much, sir.
Thank you. So let's move on to the next case, Vardhaman.
Yes, I think after this wonderful case by Dr. Aarti, now we have the second presenter, Dr. Sahiban Sethi. She is from Gurgaon. She is currently the consultant of glaucoma and cataract at the Arunodaya Dasarath Eye Hospital. She has been trained at the prestigious Shankar Netralaya for her glaucoma fellowship, and she's one of the early adapters of MIGS technology also. So over to you, Sahiban, and to discuss her case, I would like to invite Dr. Suvira and Dr. Nikunj as the expert discussants.
Thank you so much, Dr. Vardhaman, and thank you, Zain and Dr. Harshul, for having me here. So is my screen visible with the video?
Yeah.
Yes.
You may proceed. Yeah.
Right. So I'm going to be presenting this case, which is a case of a 31-year-old male who presented with traumatic cataract with zonulopathy following blunt injury. On slit lamp examination, it seemed like he had at least about 2 to 3 clock hours of zonular dialysis. So I had to be very careful. The B scan, although was normal, and I had to be prepared with my armamentarium for any sort of problems related to the zonular weakness that I could encounter. So I proceeded with my case. The staining of the capsule is already done. A 2 mm main port superior incision is made, and the AC is being formed with visco. So I went in with my Utrata forceps, and the fact that there was difficulty in pinching and grasping the anterior lens capsule itself also was suggestive of the fact that there could have been a loose bag, loose zonules. So anyway, the cystitome was used to nick the capsule, and a very gentle, controlled rhexis was done, avoiding any pull on the zonules, and I managed about a good 4 mm central capsular rhexis. Thankfully, the cortex was soft, and as soon as I entered with my phaco probe, however, what do I see? That there was a large pre-existing PCR. So the good part over here was that I did not panic. I paused. First thing I did was re-strategize. I reduced all the phaco parameters. Without pulling my probe out in a reflex, I first formed the chamber with viscoelastic and then pulled the phaco probe out. Now my next plan was to go in with a cutter, and the rest of the cortical aspiration I had to ensure had to be done in toto without any of these soft fluffy material falling into the vitreous cavity. And also the fact that there was no hydrodissection was done, so there was sticky cortex, no and gentle separation had to be done to avoid any exaggeration of zonulopathy. So all of that had to, all of this required a lot of patience, a lot of perseverance, and I was able to ensure that right now in this video you can see that there is a small piece that was trying to fall posteriorly, but it was caught in time from running out. So a lot of attentiveness to where you are also has to be very dealt in with a lot of attention. So the entire lens aspiration also over here, if you notice, is done without switching hands between the cutter and the irrigation. Also ensuring the fact that there was no AC fluctuation and there was a very large PCR. So this could have resulted in this loose cortex falling into the posterior cavity. So in the end, I was able to successfully finish the entire cortical aspiration, and there was an extremely large PCR that was pre-existing. So now my plan was to finish the rest of the anterior vitrectomy and place a 3-piece IOL. So the main port is being extended, and a 3-piece IOL is first placed in the sulcus, and then the optic is dialed into the bag with an optic capture. So since the session was about making mistakes and learning from it, I think one pointer that I'd like to say was that maybe going in with the phaco probe was the mistake that I made over here. With traumatic cataracts, one needs to be prepared for even a pre-existing PCR, even if the B scan is normal. And I should have probably, as a primary setting, gone in with my cutter and finished off the case, because this was also a soft cataract to begin with, and I didn't really need the phaco probe over there. And anyway, the case was done perfectly well, and the post-op results were excellent, and the patient is happy. Thank you so much.
Yeah,
all right.
So very nicely managed overall, Dr. Saiban. Am I audible?
Yes, sir, you are. Thank you so much.
So basically, just wanted to know what was the gap between the trauma and having this macho cataract?
So 3 months.
3 months. So I think it is relatively, let's say, a faster maturation, can be small indicative of having a pre-existing PCR, also history of trauma as well. And I think one thing that I've seen is that you did not do hydro, I believe, in this case, right? No. Yeah. So I think that was one thing that everybody should learn, because if you have a macho cataract with trauma, always have a suspicion of pre-existing PCR and avoid doing hydro procedures as such. One thing I would like to ask you is that at the end, you have actually extended the incision to implant a non-foldable lens. Any specific reason that you did not choose a foldable 3-piece?
Well, this is an endless argument about, the affordability, the cost issues, and what is right for the patient. So, yeah, I wouldn't really say this was an ideal setting. I could have used a foldable 3-piece as well. But then again, like I said, that this was an affordability issue and I had to resort to this. I did put a suture in the end because of time crunch. I could not include that. This was already a 4.5-minute video. So yeah, a suture is a must. That's also another point that I want to make. If you have any sort of PC disruption, a suture on the main port, which is especially the ones that are extended, have to be put.
So my question to you is,
We'll have Dr. Subira, yeah.
Let's work backwards. Why would you want to put a suture in any wound where there has been a PCR? Could you explain why we put in a suture there?
Just to maintain stability, ma'am, because an eye which has already had a disruption of PC, some loss of vitreous, you don't expect the stability or the eye hardness to be as much. So you don't, and especially with patients like, the kind of patient that I was operating on, you have a tendency of them to rub their eyes. So vitreous prolapse or iris prolapse, all of that could be.
So the reason why I would put in a suture in a patient who's had a PCR is the fact that if you've ever seen, vitreous blobs and tags the day after surgery, the vitreous will always follow the path of least resistance. And that typically is the incisions. And you therefore don't want vitreous tags coming into the incision. Why? What is the commonest complication you can have with this 1 month after surgery?
End off.
Okay, and end off is, yes.
Any RDs, of course, any traction on the vitreous may rupture the retina.
Just a minute, sorry, yeah. So you could have, so that's my reason why I would always secure incisions if I've had a PCR. Now we get to the beginning. What lenses did you keep ready for this patient, knowing that anything could have happened? So one was a regular monofocal and a 3-piece. May I ask what company this 3-piece lens is from?
Ma'am, this is Biotech.
Okay, all right. Okay. Is there any particular reason why you didn't use a foldable? It is difficult, no doubt, because 3-piece lenses, even my most senior colleagues here will agree, have a mind of their own. आप खोलोगे एक तरीके से and it opens the way it wants. So it's always, did you use that option because you had a compromised bag and you wanted it to be simpler, slightly more controlled?
In a way, yes, ma'am. And also, I think because I did not have a Translon,
yes,
that is also something that I did not use. Another, I can be caught with this case in many places because this was...
They're all learning here, darling.
The case was meant to be for this purpose, that these mistakes come out and we can learn from it. So during the surgery, I did not feel that there was much of vitreous disturbance in the AC. However, that still doesn't forgive me for the fact that I did not use a TA. And because I did not have that at hand, I felt that maybe extending my incision and putting it this way would have been a little easier for me. This was also a very big PCR, so I again wasn't sure. So there was the delivery of the IOL in the anterior chamber first and then dialed into the sulcus.
Is there any preoperative investigation you could have done, or maybe you did do and didn't tell me, which is specific to trauma, which sometimes tells us a little bit more, because there's always a limitation to what our eyes can see, right? And even what an ultrasound can tell you. Is there any other test given an opportunity?
I don't have a UBM in my setup, and even an ASOCT that I have is actually an attachment to the posterior segment OCT, so the penetration is not good enough for me to have pre-assessed a PCR. So also, I would also like to say that in a B scan, a PCR with a large pre-existing PCR is only possible to be noticed when there is also prolapse of the cortical matter into the
Correct. Do you have access to UBM in your city?
No.
Because we don't have UBM in our center. Okay, that's all right.
I think only AIMS has UBM over here.
All right.
See, one more thing, Dr. Suvira. Whatever investigations you do, you should always explain to the patient that there may be PCR, there may be nucleus may drop, you may need vitrectomy, you may need posterior segment approach. So these all things should be explained
Very
well in
much so,
advance.
because
Yeah.
you can go safely and operate on these cases only when
Yes.
your patients
Yes.
and their relatives are completely aware of
Yes.
what the different
Yes.
consequences are likely to be.
Yeah, and as Dr. Vardhaman said, in a white mature cataract, traumatic, not only traumatic, even in a white cataract, you never know what lies beneath. So you should always go and check the other eye to see if there is any hidden posterior polar, true posterior polar cataract. So that's why in any kind of white cataract, you can't see posterior capsule. You should never hydrodissect. That should be the rule.
Yeah, and you actually mentioned that you probably should have gone in with a vitrector and eaten up the cataract. I don't think you were really wrong in the way you
maybe just
did.
an eye also,
Yeah.
ma'am.
Yeah.
I think no. Initially, I actually thought that maybe just going in with an irrigation aspiration itself would have been good
Very
enough.
often that's enough. Yes.
Yeah, that was the point I was going to make. Of course, a vitrector is only indicated when you know for sure that there is a PC disruption, which I did not at the start of the case.
How many clock hours of zonular dialysis were there clinically when you saw the patient, Priya?
About 2 to 3.
Do you think it would have been a good idea to consider putting in a CTR after in any blunt trauma?
Sure. I was ready. I was ready to do that if it was indicated. But then in the course of the surgery, I realized that was really not the worry. Probably I overestimated the amount of zonular weakness. The main problem was the PCR, because throughout the case, the bag was absolutely stable. It did not move. There was no problem of any sort. And I could have overestimated that on my slit lamp examination. Again, since I did not have a UBM, I don't know quantitatively how many clock hours to be sure.
So then it becomes an open discussion to all. When you have a preoperative zonular dialysis and you take the patient on table, this is actually for the panelists to discuss. What is the correct timing of putting in a CTR? I personally, if I get my rexes right, I tend to put it at the beginning of the surgery, because it gives me a lot more control. There's some who think use it later whenever you want to, and I think that's based on personal experience. So
Dr. Suvira, Dr. Sethi, I think that was a very excellent case. What I really liked was the way she handled the cortex with the cutter itself. I think that requires a lot of training and expertise.
Well done.
And also, if she had put a CTR right in the beginning, maybe with such a large PC rate, it would have been little problematic. So that probably everything happened for the right.
Best,
but
no
I
doubt.
feel I just have one comment. Whenever you have a large PC rate, and in a case like this, probably if you had seen, normally if you have a normal lens and if there's a capture, if there's a damage, normally it is swollen, the lens tend to come anterior, and you can actually see the volume of the whole cataract on the slit lamp. In these cases, maybe in the hindsight, if you have seen, the lens will be slightly not coming anteriorly. There will be some amount of fluffiness in the entire substance of the lens, indicating that there is actually a breach on the posterior part. It may probably do good without having a UBM also. On a slit lamp examination, a case like this, you may probably find that there is some kind of a retroposition of the lens contents, rather than what you see in a typical fluffy, swollen, traumatic cataract. So maybe if you probably see such next time when you probably have it's very rare to have a combination of a large PC and traumatic without showing up anything. So, but it was a surprise on the table and was very well managed. I think congratulations.
Thank you.
Nikunj has to add, yes.
Yeah, it was an excellent case and very nicely managed by Dr. Saiban. She's an excellent surgeon. One thing another point is that she got her access very controlled and very right in the location also. That's why at the end of the surgery, despite having a large PCR, she could implant the 3-piece IOL and optic capture it. So that is one important thing, to have a good access in such cases. So even if you end up with a large PCR, you can implant this 3-piece lenses. I would definitely prefer a foldable 3-piece, but according to situation, you have to choose what you have from. Another important thing I would like to ask also, and it will be for all the panelists, that when she was removing the cortex using just the cutter and the irrigation part. So for the benefit of other young surgeons, it is important to explain when to use the IA cut mode and when to use the cut IA mode, because when you are handling the vitreous, it is different. When you're handling the cortex using a cutter, it is different. And would you prefer putting hooks in that area of the zonular weakness? It is lucky you are lucky that it did not get stretched in more area, but otherwise, is it a wise idea to put just capsular hook when you are using the cutter and as a IA and for the cortex removal with a large PCR?
Okay. So to answer your questions, Nico, thank you so much for the introduction to this and saying that this was a nice case. Thank you. So now the first part of your question asks me when to use a cut IA, when to use an IA cut. So now initially when I entered with the cutter, the first thing, of course, I had to do was do a vitrectomy. It was a very large central PCR and there was like a vertical hanging blob of very soft cortex. So I could have lost it at any point. So of course that had to be first the mode that I was in was cutting. Then once the central area was cleared and I was targeting only the cortex from the equator of the bag, that is when you switch to an IA cut. So basically the idea is that when you're sure that you've broken all the adhesions from the posterior capsule of the posterior cavity of the vitreous, that is when you switch to the IA cut to remove the peripheral cortex. Now coming to the second part, about the capsular rings. See, again, like I was telling Dr. Suvira also, that initially on my slit lamp examination, I did think that maybe the zonular weakness could have caused a problem. But even when I was doing the rexis, when I was pulling at the area which I assumed was suffering from zonular dialysis, I didn't really feel any pull in the bag. So it was, I could do it comfortably. I could do it with as much resistance even in the other areas. So I wasn't really anticipating much of a problem over there. And even when the cortical aspiration was being done, if I did feel that there was loosening of the bag, any exaggeration of the zonular dialysis, I wouldn't have hesitated to stop there and then put this the capsular the hooks and then yes, and then proceed. So I think it depends on what you see. I don't think you should overzealously also put in all the instruments, all the gadgets that you have. Take the decision based on what you need there and then.
Thank you. I think that was wonderful case, Saiban. Thank you so much for sharing this.
Well done.
Yeah.
Thank you.
So let's move on to the third case. Dr. Zen. Are you there? Okay. Yes, Zen. The third case.
Yes, sir. So, thank you, Saiban. That was an excellent demonstration. And now we move to the third case, which is by Dr. Aniket Jinodia. Dr. Aniket is a consultant at Susrut Eye Foundation and Research Center, Kolkata. And he's done his post-graduation in ophthalmology from Vaidehi Institute of Medical Sciences and Research Center, Bangalore. He's had a long-term fellowship done in cataract and refractive surgery. He's presented many papers, posters, and videos, and won the Best Free Paper and Best Video awards. So over to you, Dr. Aniket, for your video. It should be 4 minutes in duration, and Dr. Gopal Raju sir and Dr. Nikunj will discuss the video.
Thank you so much, Dr. Zan, for this introduction. And thank you, Harshul sir and IIRSI and YOSI for giving me this opportunity to present. I'm sharing my screen. Is it audible, isn't it?
Challenges and complications of breaking common. So,
It's a little soft.
posterior polar cataract.
Dr. Aniket, the audio is not coming. Either you can do a voiceover or increase the volume. The voice is not coming.
Okay, sir.
That by using iris repository free entry cortex from entry capsule. A small
I think Dr. Aniket,
You
you
can
can
probably do a voiceover. You can talk and mute your screen.
Or Aniket, you unshare. I'll share from my end. I have your video. Or you want to give voiceover?
Sir, it's so it's not audible.
No, it's not audible. Either you can mute this video clip and give your voiceover now, or I can share
So
from my
you
end.
can share, sir. That is also fine.
Okay. So you stop sharing it, and I'll share the screen. Yes. Then let me know whether.
Yes, sir.
So I'll forward it a little bit, Dr. Aniket, whatever part are needed.
Fighting an uphill battle. I've no financial interest. Challenges and complications are very common and ad hoc. So, what I believe is, if it doesn't challenge you, it won't change you. This is a case of posterior polar cataract.
Hello.
Notes,
Yeah.
staining, rexus
ఒక్క నిమిషం
reduct,
ఉండండి బాబాయ్ బ్యాక్గ్రౌండ్ లో
hydrophilic dissection done by using iris repository to free anterior cortex from anterior capsule. A small trench is made to achieve hydrodelineation by inside-out technique. Until now, yes, was going well. But as I tried to achieve good hydrodelineation, suddenly iris prolapsed from the main port. An unexpected surprise I faced. Attempted multiple times. Unfortunately, it didn't work and led to iris bleeding. Three situations: PPC, IFIS, and bleeding in the anterior chamber. What to do now? Here, I decided to place two iris hooks. My aim was to taut the iris to prevent further prolapse. So the challenges while placing the iris hooks: first, the capsular access was already done, so there was a chance to tear rexus margin. And second, hooking the capsule bag in place of the iris.
So if we can skip a little bit here.
Yes.
So with proper
just the iris iris hook.
Here,
just a little
I
bit.
continued with placing
till the iris hook, sir.
But during the second hook placement,
little
I
bit
hooked
more,
the
sir.
capsule back. As we can see here, the movement of the bag. So immediately I dislodged and placed properly.
So little bit more steps.
Still, purpose didn't solve, as iris again prolapsed. What to do now?
So, Dr. Gopal Raju, if you're there, yeah. What would have been like your strategy at this time? Where would you like to place these iris hooks? Are these positions the right place to try to prevent it prolapsing it further? What do you feel? Nikunj or Dr. Gopal? Yeah.
I think the wound construction was
little weak there. So that is main reason for the prolapse. And then the second reason is, Ankit, like, is it a positive pressure inside?
No, sir. The case actually after the surgery, when I asked the patient told they have on the tamsulosin, and because I think because of there are two reasons. One is the IFIS, and the second things might be the incision is uniplanar, that may cause this to pop out.
Yeah. So like Arshul said, the iris hook should have been below the wound, and then if you hooked it, so the thing is, so thing is when you have reposited it like this here, see, once you have reposited it here nicely, so after that you should place the iris hook in sub-incisional area, no?
Yes,
right.
That is the option.
That would have.
Yes, sir.
Yeah.
But at that time, sir, in my mind, when the bleeding and everything is there, it strikes like I should put a 2 iris hook and to thought the
purpose didn't solve, as
Yes,
iris again collapsed.
For us, it is very easy to comment now, and I know how challenging it is at that time. Yeah, please go ahead. We'll complete this.
As I had to go inside with the phacoprobe for emulsification. But in this situation, I might have caused iris trauma or iridodialysis. Instantly an idea came. Why not to use iris repositor to counterpress the iris and proceed ahead? I did the same. Also, I reduced my routine phacoparameters.
Can we skip this phacoemulsification part a little bit?
Yeah.
For application and aspirate cannula to remove. Again popped out. But this time I didn't disturb the prolapsed iris and proceed further and complete it carefully. Now it's time to implant IOL. Again, I used the same technique for IOL implantation with the help of iris repositor, and IOL was well placed in.
See, I think again at this place, when you reposited the iris, if you just put a blob of high molecular weight OVD there, below the,
Sir,
just above the iris. Yes.
I already put it, sir, but it was not working properly. It's still coming out, sir. That's why I just put with the spatula and counterpress the iris.
Yes.
I already used this code, sir.
Followed by the intracameral pilocarpine and moxifloxacin. And in this,
sir, last one take-home message was there, sir, in the end, sir.
Okay.
Yes, sir.
Okay. I'll just. It was a very well managed, Aniket.
Thank you, sir.
Yeah, you have done one good thing is instead of in the IA stage, instead of repeatedly repositing it, you allowed it to plug the wound and then you completed your job.
Yes, sir. Last one take-home message was there. So if we can share that screen once again.
You can tell otherwise.
The same thing, sir, that iris repositor plays an important role in this type of situations where we cannot where in this type of situation. And the other thing is we can use it like the iris hook in the main port also we can use to in this situation.
Yeah. This is one. Otherwise, then other alternative. Otherwise, initially put a suture and then make a more corneal and long,
Yes, sir.
lengthy tunnel in some other place,
Some other place. Exactly.
if it is feasible, and then complete the surgery.
Yes.
It's fantastic. Very well managed.
Thank you, sir.
And then another good decision you have taken is putting a suture.
I have already
Yeah.
put it a suture, sir. Yes.
Yeah. That's a good decision you have done.
Yes.
That. Okay.
Very nicely managed, Dr. Aniket, and
Thank you, sir.
Gopal Raju sir told you that what as a backup plan you can have. You could have put a different incision.
place,
You could have
yeah.
taken a different incision site and suture the original one. Apart from that, a small mistake which could have ended up in a bigger trouble for you is that when you were putting iris tubes, there were a lot of blood inside, and your view was blocked. That's why possibly that you caught the capsular margin while putting the iris tube. Can you at least notice?
Yes, sir.
You notice that your the IOL bag, the nucleus was moving, and you caught it on time. But otherwise, if you pull it forcefully, then it can cause a radial tear into your capsular access margin, and it can give you a bigger troubles. And another important thing is when you have if you have a iris prolapse when the first time, and when you are repositing it inside the anterior chamber, putting OVD over it, and again you are entering with your phacoprobe. I still not I was not able to notice that whether your irrigation was on when you are entering. If you go with irrigation off, just slowly enter the anterior chamber. And if you switch it on later, then sometimes the iris cannot come out again.
I
I
did
mean, that
the
is
same, sir.
another trick. Yeah.
Yeah, I did the same, sir. Irrigation was not on at that time.
But nicely managed. Amazing. Congratulations.
I think Dr. Suvira wants to add something. Yeah.
Once the iris prolapses, the tendency to prolapse is going to be there for the rest of the surgery. It's hell, irrespective of your seniority and experience. Right at the end, I saw everything was, you went in with a repositor through the main incision itself to put it in. Now, when you've got most of it in, anytime you go through a larger incision, where it's prolapsing from to put it in, there's often a tendency that as your instrument comes out, the iris comes out too. So it's always safer to go in from the opposite side or from somewhere else and pull it in. You're more likely. And I think I teach all my students that if you've got such a nasty iris prolapse, as Dr. Raju said, to reduce the trauma on the eye, I would tend to take a suture, take a brand new incision, and start afresh. That's likely to give me a lot more control because you had the entire surgery to do, no?
Yes.
Yeah. But I think that was exceptional skill set shown here. Thank you.
Thank you.
Very nice, Dr. Aniket. Yeah. I think, thank you so much, Aniket, for showing this wonderful video. And let's move on to the next presenter. And next we have Dr. Rohan Mehra. And to discuss with him, I'll request Dr. Suvira and Dr. Karan, who has joined, Secretary of YOSI. So Dr. Rohan Mehra is, we all know, is a prolific young surgeon who is proficient in cataract and refractive surgery and at CKI Institute Saranpur and Vision Eye Center, Mumbai. Welcome, Rohan. And I'll request Dr. Suvira and Dr. Karan to discuss this case.
Thank you. Thank you so much, Dr. Harshul sir and YOSI for this opportunity. So my case is not a Kung Fu Panda case. It's something very pretty simple, but I thought that there are a lot of learnings from this case, and that's why I thought that this would be helpful. So I'll just share my screen. Is my screen visible, sir?
Yes.
Yep, all good.
So is my voiceover? Can you hear the voiceover?
No, we can't actually.
Did you enable the share sound option when you started sharing, Rohan?
No, I didn't, sir. I'll just do that.
Yeah, so just unshare again and turn that option on. Unshare the screen.
Sir, on the taskbar there are more options or three dots.
View options, yeah.
There will be on the sharing taskbar. Just click on it. It will have share sound in it. 3 dots or more होगा लिखा हुआ on the sharing taskbar, sir.
Yeah.
Please go ahead.
No, so my voiceover is not coming.
Voiceover is not coming, sir.
Yeah.
But music is coming.
Yeah, music is coming, but the voiceover is not for some odd reason. So would you have
You
that
can
video?
mute this. Yeah, I think I must be having. Can you unshare once? Yeah. Nah, Rohan, I don't have. It must be in. Can you give voiceover?
Okay, I'll just give the voiceover like that only. So I'll just put it
Yeah,
on.
yeah.
Yeah. Okay. So on a Sunday evening, I was sitting and having a mud pie, enjoying my mud pie, and just to know that on Monday morning, this would be my OT list. So this was the first case that day. I stained the anterior capsule with Trapan blue and made my incision. Once the incision was made, I used dispersive viscoelastic, since I thought that there would be a lot of white liquid that would come out of it. But to my surprise, my good surprise, actually there was not much that was coming out of it. So I went ahead and I planned this surgery just as a regular surgery would be. And I thought that, well, maybe that sin of having that mud pie yesterday has not flown on me today. And I was able to make the rhexis without any liquid coming out of it. But the moment I tried doing a hydrodissection, as Dr. Vardhaman also just mentioned, you never know what's actually lying underneath. The moment I did that hydrodissection, everything, all that liquid, it just came out exactly like the mud pie that I was having on the previous day in the evening. And once that was out, you are blindsided. So once you're blindsided, you really don't know what has happened, whether the rhexis has given way, and how much of the liquid part has come out, and how much of that liquid part is actually remaining inside the bag. But pleasantly, it was mostly just cortical matter. There was not much solid nucleus in this particular case. And with epinuclear settings itself, I was able to manage this case and remove all of the nucleus and the cortical part. The rest of it was, of course, handled by irrigation and aspiration. Just a second. Pardon me, this is the wrong video, I think. So can I just take 1 minute and share that video?
Yeah, can you unshare? I think I opened the mail. It must be there. Just unshare, yes. Let me try what you sent, no?
Mud pie.
This was the one, yes.
Echo probe with the epinuclear settings, and to my relief, the entire liquid cortical matter was gobbled up by the probe in one go. The next case on my plate that day was another intumescent mature cataract. And again, I started with injecting trypan blue dye, and this time decided to make the rhexis using a cystitome. Carefully lifting the flap and waiting for the eruption of the volcano with the gush of white liquid. But to my pleasant surprise, it was not there. I took a sigh of relief and continued on my merry way to complete the rhexis. Just as I was finishing the last bit of the rhexis, it started to go away from me. Identifying the alarming situation, I decided to switch to a microrhexis forceps and carefully performed the little Brian's maneuver. Just as I was finishing the pull, out came my sins from the previous evening and the oozing of the white liquefied cortex. My breath stopped and I thought that the rhexis had run out. But God was kind. Injecting viscoelastic showed me the complete rhexis was made. Trying to rotate the nucleus resulted in more liquefied cortex oozing out from the same spot. Once I knew that the rhexis was secure, I went ahead with the phacoemulsification. I made sure that the force is least applied in the quadrant from where the cortex has oozed out. In such cases, the nucleus becomes extremely wobbly as the cushion of the cortex beneath the nucleus is lost, and the nucleus moves like a cradle in the bag. The irrigation and aspiration was tricky as the PC was very flimsy. IOL implantation was straightforward as the rhexis was well formed and intact. The learning here was that it is not necessary that the intumescence of the cataract will come from the center. It could come from any part of the nucleus, and one should be anticipating it all the time. This is how I finished my yummy OT and learned that the oozing does not come out only from the lava cake and the mud pie. Thank you.
Okay. So that was very nice video, Rohan. Over to you, Dr. Suvira and Nick and Karan.
Hi, Rohan. How are you doing?
Very well, ma'am. How are you?
So my first question, when do you decide about the nature of the cataract? Do you take a lot of time on the slit lamp to evaluate, is it intumescent? Do you see, dark gaps signifying intumescence? Do you look whether there's a dense sclerotic nucleus inside? Because I do that even today, because that then tells me how I should proceed when I start my rhexis. At what point do you decide the kind of cataract
Yes,
to begin with?
Ma'am, generally I decided on the slit lamp itself.
Okay.
But what I've noticed on a lot of cases is there's a lot of masquerading that is happening. So once that top layer is actually removed, the picture becomes totally different. Once the capsule is removed after doing the rhexis, sometimes what you see is that right from the center, there is a triangle on the slit lamp that you'll see there is a sort of a bulging right in the center. In those cases, you very well know that, the moment you're going to puncture it, all of that liquid is going to come out. But in a lot of cases, when that is not present, what I have noticed is that it actually comes out from the periphery. And this has happened on multiple cases.
So now suppose you were expecting it to be an intumescent cataract, like intumescent, as in both the cases you expected the fluid to come out. Is this your preferred choice of doing a rhexis? I mean, it's like a pretty large circular rhexis you made, which always has a tendency of going out to the periphery in all our hands.
Yeah, so this is what I learned. This is exactly what I learned after this OT, that what I generally tend to do is that if once I've given my central nick and there is no intumescence, nothing has come out, so I feel that the lenticular pressure is not that high, then I generally tend to go for a normal size rhexis or a bigger rhexis.
Is there any particular viscoelastic that you would prefer when you expect it to be an intumescent cataract?
Yeah, would put a heel on, ma'am, something heavier to actually have the pressure inside the lens and in the AC to be equivalent.
I feel using a heavy duty viscoelastic, it could be even hyaluron, it could be orogel, it could be viscoat, whichever one. Once you try and flatten the anterior capsule, that's the first point of control. Second, I make my capsulotomes. I thought that your bend of your capsulotome was pretty large. Do you know how large along the bevel is? The bevel is 2 millimeters normally in a 26 number needle. So I tend and I teach that you should bend it just 1/3. I find a very large bend gives you a lot less control. A small bend, checking that the tip is not faulty, which sometimes happens because of the needle holder. And under a heavy duty viscoelastic, I would tend to make a small circular rhexis, always, which is not more than 2 or 3 millimeters. I would keep an intraocular forceps at hand, which would help me navigate it through. Because should there be intumescence, you're not going to have that firm surface over which आप system bend करके drag कर पाओगे. So you need to have a paracentesis large enough to house a forceps which you have ready at hand. And the safety buffer is always performing a double rhexis, because once you've done one, then I go in with whatever I want to, whether it's bimanual eye or hydro, and wherever the darn intumescence is, it comes out. I flatten the capsule. Again, I make a nick. In that way, because how do we raise our bar in surgery? By being able to achieve consistency in our results. So you got to formulate for yourself a short plan कि intumescence हो, बीच से हो, कि दूर से हो, जहां से भी हो या नहीं भी हो, I should have a fixed plan which is going to give me consistent results. Because should it be intumescent even in the periphery, and you've got a slightly larger rhexis, you're not always going to be as lucky as you are now getting the rhexis back. And however experienced a surgeon, you lose your rhexis once, we all lose our cool. That would be my guidance to you. But otherwise, I think very nicely shown. Thank you.
Thank you so much, Suvira.
Excellent,
Karan?
yes, sir. Excellent surgery, Rohan, as always. You're a fantastic surgeon. And I would just echo the same point that Suvira ma'am has told. Like, I also like to always do a double rhexis and then remove all the liquefied matter and then do the second part of the rhexis. An alternate is the spiral rhexis, though. One question to you: what is your choice of phaco? Do you do stop and chop in all cases, or do you do a direct chop?
I do a stop and chop in all my cases.
Okay. And what was the grade of the cataract, particularly in the second case?
The grade of the cataract was about an NS 3 to 4.
But was it smaller? Was it a small nucleus because it was floating?
Yes, yes.
What I do, what my suggestion would be in such situations is, I like to grab the hold. My choice is direct chop. I do that in almost all my cases, except a few very hard leathery cataracts, big ones where I do a crater and chop. So this case, I would go inside, bury it, and I make it the nucleus slightly tilted. And once it's tilted, I go with the chopper behind, with the chopper behind like this, and I just make a crack directly there. So when you're doing stop and chop in such situations, I feel there's a lot of stress on the zonules is there because you're moving it. So this eventually helps to manage that situation. Otherwise, an excellent surgery.
Thank you.
Thank you so much, Rohan, for showing that wonderful case. Yes.
Thank you, sir.
So, Dr. Zen, where is he? Zen goes in operation theater in between, I guess. Okay. So I think I have to go next now, and the plan was something different, but looking at the wonderful surgeries with everybody showing, I think I need to show some challenging cases, and like to share one or two cases quickly because we don't have much time, and still there are 4 speakers to go. So let me take you through one of the case. This is a recent case. Can you see my screen, Karan?
Yes, sir, we can see your screen.
Okay. So there's a case which is planned for toric IOL. So the axis was marked here. So I always use a 26 gauge needle. So it makes a very thin marks there. So once the marks are made, there's a routine surgery which is going on. Side ports are made and rhexis is made. There was a posterior subcapsular cataract, and this is the hydrodissection cannula, which does good hydrodissection. And I go ahead and do the chopping. So this is a nucleus which is coming off. Nothing great. So it looks like a normal routine case. So once I finish with nucleotomy part, I go ahead and put viscoelastic before I start irrigation aspiration of cortical matter and keep a watch here. And this is a visco cannula, and I'm injecting viscoelastic, and suddenly viscoelastic cannula jumps. See, in slow motion, it goes, pops out from the syringe, and it ruptures, most likely post-A capsule, and I'm not sure the status of anti-A capsule. And this case was planned for toric IOL. So at this stage, we are not sure that how much damage it has caused. So here I go ahead and put irrigation cannula. I'm just spraying that it does not damage anything, but as I put irrigation cannula, I can see that vitreous is coming out. So straight away, I do visco exchange. Now, once you know that there is a PCR, there is vitreous, now your aim is not to let your anterior chamber collapse. Whatever damage has been done, you need to now take care of that. So I go ahead and put viscoelastic there, and straight away I go ahead and get my cutter. So now, as we were discussing, you need to use bimanual vitrectomy here. So you need to separate irrigation and your vitrector. You are in cut IA mode, because when vitreous is there, first you need to clear off entire vitreous from anterior chamber before pulling it on, because traction may cause peripheral retinal tear. So here I go, and I'm doing vitrectomy starting from here. And once I do little vitrectomy, then go ahead and again I'm putting this tricot there to check for the presence of vitreous. Sorry. And go ahead. So your goal is to now remove the entire vitreous from the anterior chamber before you can take off the remaining cortical matter which is there. So again, I'm doing visco exchange, and now I'm in IA cut mode, because at this stage entire vitreous is gone. So you just have to take care of the cortical matter which is there. Okay, so you can see here now a big post-A capsule tear which is there, and I can also see the tear in the anterior capsule. So again, I exchange my hands. I'm on IA cut mode, taking off the entire cortical matter. So at no point of time you should allow the anterior chamber to collapse. Again, exchanging with viscoelastic, and you can very well appreciate that anterior capsule is torn like this, and these are the toric marks where toric IL to be implanted. It was 2.5 diopter of cylinder, cornea cylinder. So, Dr. Subira, what now?
I think that, I mean, one, you've got a PCR. Two, you've got a tear in the anterior capsule. So you don't have support either behind, and definitely you don't have support in front. Even if you've done a great anterior vitrectomy, which you have, even though you have a tear which is limited, I might still be brave enough maybe to put a 3-piece IOL in the bag, but putting in a toric and being able to hope that it remains stable is a little challenging, I think. I would not consider toric IOL with my level of skill set and with my ability to be that brave that it will stay where I want it to stay. Because to stay where it needs to stay, you need the optic sticking to the PC with the hydrophobic material. You need the haptics to be a butt at the equator, and you need a nice cover of your rexes. All three things are needed, in my opinion, to keep a toric IOL. Tab bhi 6%, 8% ghumte hain. You see, so that's, I wonder, this is what I would say.
Yeah, so problem is anterior capsule is torn, PC is torn, and something like this. Dr. KP, any other views? Or?
Yeah, I think toric will not be an option. As she said, we have to put a 3-piece. perpendicular to the area where the anterior capsule has torn, and maybe just manage the astigmatism either with glasses
Yeah.
or maybe touch the cornea later.
Yes, yes. So three-piece IOL, see, of course, it was not a posterior polar or something that we had a three-piece IOL in the inventory. So at that time, I thought exactly the same as Dr. Suvira and Dr. KP are saying that, of course, toric IOL can't be put here. So I just go ahead and deferred the IOL implantation after a day or two. So I go ahead and just completing the vitrectomy there and closing the incision. So after a day, in second sitting, I go ahead and plan a three-piece IOL, and now you can see it. Everything is clear, so clear that. So as we were discussing, yes, it's a little tricky to put a three-piece IOL because we don't put it often. So the trick which helps here is to always keep the haptic which is coming out horizontal and beneath the iris. So the wherever the haptic is going, you just try to rotate your hand so that it opens horizontally beneath the iris, and then you can rotate in anti-clockwise direction so that you have the haptic IOL opening up in the sulcus, and the trailing haptic you can dial in the sulcus. So I go ahead and put a three-piece IOL in the sulcus there. And
Harshul, why you deferred? Do you have any hope of putting the toric
no,
lens next day?
No. Three-piece IOL was not there in inventory that
Okay,
time.
okay,
Yeah,
okay.
yeah,
That's fine.
yeah. So that's why. That's the only reason. If you have a three-piece IOL, go ahead and put three-piece IOL straight away.
Yes.
So it's not that we have to put some IOL, so we put any IOL,
Yeah.
Yes, Dr. Suvira.
So I just add one more thing, two things actually. One, irrespective of your volume of surgery and your number of cases that you have, I think it's important to keep a three-piece standby. You get companies like Oro that make very good three-piece lenses also, and they're happy to let you keep a little library so that you're never stuck without a lens. Because sometimes it might be difficult for patients to handle. Harshul, they probably really trust you, but the guys, if I left them aphakic, they would probably say, what the hell is this? I came for my cataract out and I haven't got a lens in my eye. The second thing which you showed very interestingly, which you didn't comment on, is the fact that when you need to put in a three-piece lens, I tend to be to make the incisions comfortably large. I don't then want the nozzle just within the incision, because if the tip of the nozzle is just within the incision, it's very difficult to control where that darn haptic goes, because it will tend to typically go in the vitreous. So a large incision, the nozzle almost towards the other end of the rexus, that's when, as it comes out, you turn it around, it'll go where you need it to go. That's what I've realized, and what I do. I used to worry that the incision is getting so big. I just take a suture, and a week later, if it's causing a significant amount of astigmatism, I would cut out the suture in the OPD under Paracaine and Septidine to take care of that suture-induced astigmatism. Thank you.
So what everybody should learn is always to check for the tightness of the cannulas, whatever you are injecting. So just before that, you should always check. So
I think Harshul, very well done. I think this is called harpooning. It's called a harpooning of the cannula. I think this every resident has to tighten, because sometimes the scrubbed assistant gives you a thing without probably really knowing it. Earlier we had lure locks. Now we don't have the lure locks. So you need to really tighten it. And also maybe just see that, especially if there's a posterior capsule is bare open, especially in situations where before putting the implanting the IOL, I think this can be a real make or break situation, but excellently handled. I think there couldn't have been any better way of handling such a catastrophe. Well done, Harshul.
Yeah. Thank
Very
you.
well done, absolutely.
Yes,
Sir, may I ask
yeah,
one thing?
Nikunj.
Harshul,
Yes,
sir?
yes, yes, Nikunj.
Sir, amazingly, it is always pleasure to watch all of your surgeries. Sir, I have one question for benefit of viewers and for myself also. That what is your preferred three-piece IOL in such situation? Because see, the ma'am mentioned about the Orolab three-piece. It comes with a push injector, and I think you have implanted a sensor three-piece which has to be implanted with a screw injector. So,
Yes,
what is the
yes.
preferred delivery method? Would you prefer a screw injector with a slow delivery or a push injector? I mean, in such situation.
See, whenever I need to put a three-piece sensor or I think matrix, there are two lenses which I use, and sensor has a screwing type of like in mechanism. So the biggest trick is just wherever your nozzle is. It's not that your nozzle has to be like this down only. Wherever your haptic is coming, you rotate it and keep it horizontal. There's the biggest trick for this. And after that, once the leading haptic goes beneath the iris and optic comes off, then you rotate your hand anti-clockwise so that the trailing haptic will come out. I think, and only we use in sometimes whenever the situation like this arises.
Correct.
Otherwise, we all are mostly using hydrophobic single piece lenses. Yes,
Sir,
Varman?
I have another question for the benefit of the young audiences over here. Suppose the ALC is intact. Would you put a toric IOL? There's a rim of PC there. And what would be the tips of implanting a toric IOL in the case with the PCR,
Yes.
but an intact ALC?
Yes. Yes. So if anterior capsule is fine, then it depends on the size of PCR. Like if and then also your axis. Like in this case, the PCR was quite, big, but still you can try if anti-capsule margin is intact because the hydrophobic material has a very tacky nature. So once you put it in capsular bag nicely, mostly it will stay there. But so the biggest trick there is you just go ahead and put the because it opens very slowly, hydrophobic ion. So you just try to rotate the lens before it opens up in the axis where it's planned, and don't try to rotate the lens with haptic. You just bend from its shoulder from the haptic and just push it in. So in that way, you can very well place a hydrophobic IOL.
So just one point I'd like to add. When we talk about a push type of injector or a screw type of injector, personally, I think even though a screw type of injector in a normal case gives you a lot more control to the delivery of the lens, it has the disadvantage that you have both hands are being used to push it in. So you don't have the advantage of the second instrument either giving you counter pressure or negotiating the IOL in the bag. Particularly for a three-piece lens, even whether it's Oro, whether it's Alcon or it's a tech sensor, I personally tend to prefer a push type because I've learned to control the way in which I push, because Technis takes its own level of learning curve to learn how to control the push. Because I have a perfect counter pressure with my second instrument, and more importantly, in an eye with a compromised bag with unpredictable haptic, I'd like my second instrument to be in the eye to help me negotiate my haptic should it be going anywhere else. It's just the last thing I want to say. Thank you.
Okay, let's move ahead.
And no visco wash behind the IOL then, no, sir. No visco wash behind the IOL.
No, if you've done good vitrectomy and everything, it can be done. That's not an issue. Yeah.
One thing, maybe small thing, and if it is a small PR, so we convert this into a PCC, and if we can do that, then there is no worry at all implanting toric IOL in the back stability. Yeah, I think we'll go to the next case.
Yes, Vardman,
Yeah,
you need to
perfect.
invite. Yeah.
Yeah. So, yeah, thank you, Dr. Harshul. It was, of course, as always, a fantastic video, a lot of learning tips for everyone. And now we have another young ophthalmologist who is going to showcase her skills in difficult situations. We have Dr. Anu Jun. She is the Assistant Professor of Glaucoma and Squint Services at the Guru Nanak Eye Center and Maulana Azad Medical College. She's currently also the Associate Editor of the Delhi Journal of Ophthalmology and Executive Member of YOSI. She is very active in all the YOSI initiatives as well. So over to you, Dr. Anu, for your presentation.
Thank you so much at the outset, IIRSI and YOSI for having me here and giving me this opportunity. So rather than anterior segment, I think I'm going much anterior to the anterior segment. I'm extraocular here. And we're going to be talking about not just learning from the mistakes, rather learning from experiences. So this was one such case that I came across, a slipped muscle. I had never seen one. I had never assisted one, let alone operate one. I had operated on squint surgeries, and what my experience taught me, I went ahead with that and with that confidence to tackle this case. So let's begin. So an 11-year-old girl had presented to us with a large exotropia in the right eye, almost 90 PDs, and she had history of trauma in January 21. That was the time of COVID. She did undergo a surgery in her regional area in Bihar, and around within 1 to 2 weeks of trauma, and a laceration repair with reattachment was noted at 5.5 mm from the limbus in her records. However, the mother complained that she developed a further larger squint in the postoperative period, and that was the query of concern. So as you can see here, the right eye adduction was grossly limited in left case, and there was some amount of scar that could be appreciated. She did complain of a crossed diplopia, which was worsening on left case, but she did not adopt any posture. Convergence was absent. We did an imaging where we could appreciate the medial rectus sheath here. And so that gave me some amount of confidence in going ahead with the surgery under general anesthesia. However, since I had never operated on such case or seen one, I did counsel the parents that we're going to go and look ahead for the medial rectus muscle. But in case we do not find that, we're going to operate on the lateral rectus, and maybe the exotropia would better but not improve. And we might have to go in for a vertical rectus transposition in a second sitting on a later date. So all the counseling was done before we proceeded with the surgery. As you can see, there's a lot of scarring and there's a lot of buttonholing of the conjunctiva while we're trying to dissect this, because she had history of previous surgery as well as trauma and a scar at the slit lamp. So I think this was the key point here, that the primary surgeon who would have operated must have thought there was a muscle and had noted that this was repaired and attached at 5.5 mm. But he probably missed out on the fibers of the muscle and took in just the sheath and sutured it back. We did identify that at 5.5 mm. So we secure this for further guidance. Now we keep dissecting and dissecting and dissecting. So this looks quite easy here. However, it was more than a 30-40 minute surgery, and we kept on dissecting. So just before this, I would like to mention that I was almost about to give up. It was a patient under general anesthesia. It had already been 40-45 minutes. And I thought maybe should I stop and just go ahead with the lateral rectus surgery. And just when my patience was maybe running out, there was an ocular cardiac reflex that was monitored on the screen, and that gave me a hint that these could be the muscles. It just boosted my confidence in my skills. I grabbed onto whatever I could while assessing the ocular cardiac reflex and passed on a suture, and then tried to dissect in and around that area. The more I dissected, the more confident I became that I was on the right track inside the sheath and I was going to get a better result. And it was very gratifying intraoperatively as well to find these fibers. So quite a happy moment here to finally find these fibers, quite posterior. So a muscle which was supposed to be at 5.5 mm is actually here 19 mm from the limbus. So there was a large recession of medial rectus inside the sheath, and it had slipped quite. So you could see I had a superficial pass. The muscle had already slipped once. I did not want to take a chance here. So I tried to secure it further. You could also use a non-absorbable suture here. Since she had a slipped muscle, so a non-absorbable suture could also work well. However, I tried to ensure that I sutured it well. Conjunctiva was managed using a buttonhole technique. So one learning pearl here in managing the medial rectus is that during the first surgery, probably one pearl is that you are not supposed to pull the globe in the opposite direction. The more you try to, get access of the site medially, try to put the globe laterally in order to dissect, the more the muscle gets pushed posteriorly inside its sheath. So that can actually prove harmful, and it is better to keep the globe in some amount of primary position and keep going posteriorly rather than rotating the globe in the opposite direction like a case of a normal surgery. This was quite easy and like a routine lateral rectus surgery. I wasn't sure how much the primary muscle surgery would achieve because it was a 90 PD of exotropia. So a simultaneous lateral rectus surgery was done. As you can see, this is day 1 post-operatively. She has some congestion both medially and laterally. However, she is orthotroping in the primary position compared to a large exo initially. And the adduction has been regained fully right on day 1. Very gratifying, no diplopia, good ortho position with good motility, a happy patient. And
yeah. Wonderful presentation, Dr. KP sir. I think you are the
excellent. I think I am almost speechless.
Thank you, sir.
Because this is such a rare case. I just wanted to know what are the details of the first surgery? What was actually done in the first time?
Sir, the details differed actually as patient's history versus the records. So she had trauma in January 2021 with a bicycle handle, and the records state that she was operated on 8th Feb. Record just mentions that medial rectus found lacerated along with conjunctival laceration, MR secured at 5.5 mm of the limbus. This is the one line that is mentioned on the OPD cards that she had got on the discharge sheet. However,
probably they were trying to meddle with the conjunctival laceration. They thought it to be MR and probably they reattached it there. Probably the MR must have got cut and got retracted. That's it.
Probably, sir. Although the mother says that she underwent 2 surgeries, the records state only one. The mother says the eyes were initially straight and then she underwent a surgery, but we don't know how much to rely on it. And after the first surgery, the deviation worsened. They tried to take her up on the second time, but couldn't do much. So they referred the patient to us. And
no, but this can happen. Actually, even though after the trauma, there can be a secondary exaggeration of the deviation. As you said, as the eye starts moving on the other side, the muscle can keep on slipping within the sheath. I think this was a real test of your patience and perseverance. So I think perseverance and persistence always pays, they say. And as you said, if you move the eye to the other side, you are actually taking it more towards the orbital apex rather than away. I think one advantage of these muscles is they always retract along the sheath. So they don't go anywhere else. So other ways they probably normally describe these to basically go along the intermuscular septa. So basically you cut the intermuscular septa, go down there, move the eye towards the same side and try to catch it like with a muzzle clamp or something and try to pull it forward. If you just keep on dissecting along the muscle sheath, you may actually not get it. If you go by the side and try to kind of catch it and try to pull it forward, and using the oculocortic reflex as a electromyography or just to detect the muscle tissue was something very novel and very timely. I think there are no anything that could have been done better because this is just a very rare case. At the same time, such a large angle squint with any vertical muscle transposition or any LR surgery wouldn't have been so physiological. I think you really, because the muscle normally after a long time, probably if the time is too much elapsed in between the two, the muscle may not really work like before. And such an amount of retraction, there would have been definitely some contractional changes. So getting it back there and putting it 5.5 was a Herculean task. I definitely agree. And very well done. Patient is very lucky and the surgeon also was probably lucky, along with being very competent.
Thank you, sir. Thank you so much for your kind words.
Thank you, Dr. KP, sir. Any other panelists would like to add any points? Okay, great. So I think, Dr. Zen, can we go to the next talk?
Yeah, so that was an excellent surgery, lot of learnings for us as well. So our next presenter is going to be Dr. Isha Agarwal. She's a phaco and oculoplastic surgeon at Drishti Netralaya, Dehradun. She's trained at Sri Sankardeva Netralaya, and she's fellowship trained at Sushruta Eye Foundation, Kolkata. She's done oculoplasty observership at UCLA, USA with ICO fellowship. Over to you, Dr. Isha, and the discussants for this are going to be Dr. Gopal Raju sir and Dr. Sonal. Dr. Isha, are you there?
Yes, can you hear me?
Yeah.
So a very good evening to everyone present here. So I'll be presenting my video on a double modified technique of iris repair by sewing machine technique. I'll just share my screen.
Can you share your screen?
Yeah, I'm just trying to do that. Can you see my screen now, sir?
Not yet.
Dr. Isha, on the Zoom window, 6 o'clock, there is a green button, share screen. On the Zoom window, just click that. On the Zoom window where you can see everybody.
Yes.
And there will be a pop-up, just click again, share. Are you able to do it?
No, sir.
Then you can try sharing from YouTube. That video is on YouTube, I guess.
Yes, sir, it's there, but you'll still need to see the screen, right, sir?
Yes, sir.
Zen will do it, yeah.
Okay. Your video is on YouTube, right?
Yes, sir. So I'll just like to talk in brief before the video. So what happened was in this case, while I was performing a small incisional cataract surgery, there was a more than 180-degree iridodialysis, inferior iridodialysis. And so I asked the OT staff for a 10-O proline suture. So because of the unavailability of the 10-O proline suture, what I did was I had to improvise definitely because a solution was needed to, tackle the situation. So what I did was I basically took like we'll see in the video, I basically took a 8-O curve needle, and that is how we did some modifications. I'll go along with the video.
I'll try sharing then. Just a minute.
Is the screen visible?
Yes, I can see it.
Is this is the video, right?
No, this is I'm sharing Zen.
Okay, okay.
Wait, where is her video? Yeah.
First one, sir. The first email.
Okay, Isha has started sharing. Yeah.
So can you see it?
Yeah. We can see your screen. Yeah. Okay, go ahead.
Yes, just.
Today we had a case of inferior iridodialysis, which occurred during a cataract surgery by a fellow surgeon. So in this case, we had a 8-0 curve needle, and we were unable to thread the 8-0 curve needle. So what we did was we cut the needle, we threaded the suture through a 26 gauge needle up to a certain extent, so that we could take 3 bites from the damaged iris inferiorly. The suture was threaded well along its length in the 26 gauge needle, so that we had adequate suture inside the needle. After it was threaded, what we did was we took the first bite through the tunnel, taking the inferior iris, the last edge of the inferior iris, we sutured it to the sclera. After that, we took a second bite next to the first bite, and a loop was formed next to the first bite. Then the 26 gauge needle was taken out. The third bite was taken from the inferior edge of the damaged iris. From the needle was taken out to the sclera, and now we had 3 ends of 8-0 nylon suture. So now the middle suture had a loop. The loop was cut in between, and now we had 4 ends of 8-0 nylon suture. So what we did was we did a crisscross suture of the nylon ends. The third suture was sutured to the first suture, and the last one was sutured to the second suture. And now we had sutured the complete inferior iridodialysis to the scleral spur. We now had a round pupil. Now the suture were covered with the conjunctiva. Thank you. Now the suture were covered with the.
That was a very good video. Very well demonstrated a difficult technique. Gopal Raju sir, your comments on the technique?
Yeah, that was a very well done surgery. But the 8O, is it a monofilament or it's not monofilament? No, so can that can cause postoperatively granuloma formation, tract reaction, and other complications.
Yes, sir. Like ideally, we should have used a 10O silk suture monofilament definitely, or maybe a proline for that matter. But since I didn't have a straight needle 10O proline suture, and I had to improvise with a curved needle, so at that time in that OT, that was the available suture. So I improvised with that suture.
Yeah. Okay. I think it was nicely done.
Dr. Isha, what is the idea behind tying 1 with 3 and 2 with 4? Because, what is the idea behind that? And how
Yes.
it's different from, I think this technique is beautifully shown by Dr. Ravi, who invented sewing machine technique and then he modified it also. How it means give a different result than.
Yes, sir. So what I thought was when I sutured the first with the third, there is a crisscross while we tie it. So there are less chances of slippage of the knot. So when you tie 1 with 2 and 3 with 4, like what Dr. Ravi sir has done in his video. So he has tied 1 with 2 and 3 with 4. In that, there are more chances of slippage. So what I have done, like when I tied 1 with 3 and 2 with 4, I was crisscrossing the suture. So what I thought from this was there was less chances of slippage of knot, like post-operatively, longer post-operative periods.
The 1 is here, then when you are tying with 3, so you are pulling on the 4th one. No, because is a loop which is there, which is coming out,
Yes,
and
sir.
you cut this loop. So
Yes.
second is the one which is connected with the first. So when we tie, we practically hang back the iris to the scleral spur. and third with the fourth. So if you pull on the first and third, the third will pull on the fourth, and fourth will try to come off. No, didn't you feel that? And
No.
what is the site of? I felt that your site of the exit of the needle was too near to the posterior limbus. It should be almost 1.5 millimeter behind, where the anatomical site of, physiological site of iris insertion is to the spur almost. That
Yes,
was
sir.
one observation which I noticed.
So I kept a marking of 1 to 1.5 mm. So in this surgery, I had a marking of 1 mm posterior to the limbus.
Okay, okay.
And I have called
But
it double modified just because I've used a curved needle, and since the curved needle cannot enter the the needle, I mean the syringe, so I have cut the end of the curved needle and I threaded the suture, and which is like very easily available in all OTs at all time and during all emergencies I have felt.
yeah. Dr. KP, anything to add?
Yeah, I think even I didn't understand this 1 2 4, that 1 3, and because when you do that, you're not actually pulling the iris to the periphery. Anyway, I just need to really know how it works. Having said that, this technique is actually much atraumatic compared to many of the other techniques that has been done in the past. I think, this is a technique which has been well accepted to be where without really, trying to do too many manipulations, you get 2 loops and you can actually have multiple. So if you have 2, 3, and you can have any number with that technique, you don't have to really, you can keep on piercing it and have multiple entry points and multiple stitching points. So,
And in fact, you don't even, in modified technique, you don't even need to cut the loops. You just pass the first inside of all the loops and then tie in the end. That's what
it's like a cobblers
shown, the
technique.
modified.
Cobblers technique. Yeah.
Yeah. So
The sewing machine technique. Yeah.
yes. Very nice, Dr. Isha. Yes.
So I think we'll move on to the next video. The next video is by Dr. Sumit Goyal. Dr. Sumit Goyal is a graded specialist ophthalmologist from Military Hospital, Bareilly. And KP sir and Dr. Nikunj are going to be discussing this video. Dr. Sumit, are you there?
Sir, I'm here, sir.
Yeah. Please share your screen.
Hello.
Is my screen visible, sir?
Yes, it is.
Good evening to all present here, sir. My case is something which all of us encounter pretty frequently. My patient, a 69-year-old diabetic male with moderate NPDR in both eyes and BCVA of 6/16 left eye, was worked up for phacosurgery. During pre-operative workup, the patient responded moderately to topical cycloplegics. Hence, he was started on topical NSAID drops and tablet acetazolamide pre-operatively. The pupillary dilatation achieved while beginning the surgery was 6 mm. However, during the procedure, dilatation maintained was approximately 4.5 to 5 mm only. Procedure was planned with a focus on all the basic steps of phacosurgery. Patient was given peribulbar block to begin with, anterior capsule stained with trypan blue dye to enhance the view, which was limited in this case as a result of senile arcus and corneal opacities. The capsular axis was initiated going beyond the pupillary margin in a controlled fashion, and CCC of approximately 6 mm was achieved with pupillary dilatation of merely 4.5 to 5 mm. After main port entry of 2.8 mm, hydrodissection and delineation is being performed going beneath the pupillary margins. and the lens matter is then rotated using Sinski to ensure a successful hydrodissection. Fluidic parameters of the phaco machine, including vacuum and aspiration, were kept on the lower side to prevent inadvertent aspiration of iris tissue in such a case. The divide and conquer technique of phaco was employed to ensure minimal stress on the capsule and zonules during the phaco procedure. Also, in a moderately small pupil, it is always better to chop after creating smaller quadrants of the lens matter.
Hello? Hi? Hi, what?
Next, the IA was done using coaxial irrigation aspiration system, and it was also tricky as rex's margins were not visible. Patient was then implanted with hydrophobic acrylic monofocal IOL in the bag. And case was successfully finished. Post-operatively, the patient had uncorrected vision of 6/12 on day 1 and 6/6 on day 7. Thank you.
Thank you, Dr. Sumit. Very neatly done surgery. KP sir, what do you have to say about it?
Basically, Sumit, what was the exact reason that you displayed this case? What exactly were the teaching points or the takeaway messages you wanted to share?
Sir, actually, we were asked to share some challenging cases. So small pupil is what we frequently encounter. So what all precautions we can take while doing case of moderately small pupil, that's what I wanted to share, sir.
Okay, I mean, not a very representative case because the pupil was pretty good enough in the beginning. If the pupil can dilate to that extent, probably whatever happens intraoperatively, pupil coming down, pupil becoming really small or floppy is all basically a preventable thing. Basically, like if you can use NSIDs preoperatively, and
Yes,
if you do not touch the iris tissue, and if your surgery is a short duration, normally we may not have much problems for the rest of the steps. The pupil is dilated to 6 millimeters at the beginning of the surgery, then probably it is not a case of a so-called a small pupil in terms of definition. And second thing, you also said that we gave a preoperative acetazolamide.
Yes, sir.
What exactly was the reason to say so?
So to keep the IOP on the lower side and prevent any unforeseeable complications in the case, sir.
Normally, unless the patient has a high pressure due to a pre-existing glaucoma, normally that is not the standard of care now. Preoperative acetazolamide do not really help much, can be problematic at times, and has found to be of no use in routine cases at least. And but anyway, the surgical steps were very neatly done, and you showed all the things that has to go into a normal good case. But pupil, if it had become really smaller, let's take a situation where what you are actually referring to, the pupil really comes down to 3 or 4 millimeters during the surgery, what would you be doing otherwise?
Sir,
what would be your change of plan?
Sir, if the pupil would have gone below 4 mm size, I would have chosen either iris hooks or a Malugin ring to go further in my case, sir.
Okay, so you would, I mean, you'll choose a ring or a hook. Normally, what's your first choice?
The first choice is iris hook only, sir.
Iris hook, okay. But the only problem is, since the rex is already done, you should be a little careful not to engage the rex's margin in the iris hook. So you need to create a proper plane with the viscoelastic, and you should be very careful when you actually engage the pupillary margin with the hooks. Well done, Sumit.
Thank you.
Sir, one question I have is how small should a pupil be considered small before you think of putting a ring or a hook in the beginning? Like what kind of exposure you feel
See,
is enough
pupil
to
also
continue?
means student in English. Okay. So pupil means student. So if you are a student in your early stage of career of surgical practice, probably it can be a lot bigger. If you are a student of your surgery, a pupil of a little, after a little bit of experience, I think it all depends on Zain, on multiple factors. It does not just depend upon the surgeon. It depends on the situation, the whether how critical is the situation, and what all accessory that you are exposed to, what kind of machine you have, what is the kind of nucleus characteristics, what are the other associated features? Is there other zonulopathy or a zonular weakness? Is the endothelium on the poorer side? What is the corneal clarity? And is the patient cooperative? There are many other things that go into it. I think if there is more than, if pupil is 4 or little, I mean 4 or 5, I may not use iris hooks, okay, just to probably the save time. But if there's an associated complicating factor, imagine I also have a poor zonula, I have a very hard cataract. Okay, then in that case, if there are more than one complicating factor, I mean additional complicating factor, along with small pupil, I would always go for an iris hook or a ring. Normally, iris hook is my preferred mode. That's it. But at the same time, if I want a large rexis, the patient is a case of diabetic retinopathy needing some treatment. So I would not really want to end up my case with a small pupil. Even though I can complete my phaco, I still want a proper size rexis. I want a proper cortical cleanup. And after removing the iris hook, the pupil slightly takes a little larger position, which will be actually good for the posterior segment people also. So I think more than one complicating factor, better to play safe.
And so your choice is always iris hooks first?
Yeah. I mean, I'm not a big fan of rings. In rings, I use Gupta ring, not the Malugin. But iris hooks have been my preferred choice.
Anyone from the YOSI panel wants to comment on this case or related to small pupil? Dr. Sonal, Dr. Karan?
Yeah, actually, I was just about to say that the affordability of the patient also comes into picture here. That I think iris hooks are much more affordable and easier access. And the case was very well managed by Dr. Sumit. And I mean, I think I would also do the similar thing in such a case. And even Sir pointed out the right thing that pupil is like student. So I remember in my SR-ship, I used to use the iris hooks much more often. And like I have reduced the use so much now that most of the cases I'm trying my best to manage without use of the iris hook, though I don't shy away from it. And as Sir said, that suppose there's a small pupil and then along with it the cataract is intumescent kind, then you should really not take the it's then it becomes very complicated. Then even putting in the hooks is dangerous, and also then at that time going in and trying to do a rexis and going under the iris with the and thinking that you will come out with an adequate size and it will not extend, that is also just too much. So really knowing where to draw the line is also important. So I think yes, Sir very rightly said that there is no one fixed point for saying that okay, at this size you should do this or that. It also depends on your experience and your own comfort level.
Right.
Okay. Thank you so much. I think wonderful case, Sumit, and I think Dr. Suvira had to leave, so we would like to thank Dr. Suvira to be there as a part of the expert panel. Her inputs were really valuable and a lot of learning pearls for everyone. So I think because of the dearth of time, we will be going to the last case, which is by Dr. Dipali Singhal. She is currently a consultant of cornea, refractive surgery and external surface at Anil Eye Hospital. She's an alumnus of Maulana Azad Medical College and RPC. And she has done more than 15,000 surgeries in her career, which is quite a big number for such a young ophthalmologist. And for discussing her case, we would like to invite Dr. Gopal Raju sir and Dr. Yeah, over to you, Doctor.
Dr. Deepali, are you there?
Yes, sir, I'm there. Thank
You
you
will
so
be able
much,
to
sir,
play your
for...
video?
Yeah. Can you
Okay.
please play my video?
No. Are you going to play it or do we have to play it?
So please, you can play it, will be better. My connection is not stable.
Harshul sir, please come to the rescue.
They are not here to hold your hand. They close.
Dr. Sumit, would you please mute yourself?
I'll just do that then.
Yes.
Okay. Okay. Can you see it?
Yes, sir.
Okay.
This video will be showing the surgical technique of lens aspiration in subluxated lens. This patient is a 6-year-old child with bilateral temporal lens subluxation, bisecting the pupil with broken zonules. What are the goals of surgery here? First is to remove the lens completely. Second, to avoid any lens matter drop into the vitreous, avoiding any posterior segment inflammation. Third is to avoid any vitreous traction and retinal complications. So, among various options, I chose to perform intralenticular lens aspiration, in which 2 MVR entries are made, followed by 2 small capsular openings through which lens aspiration is carried out within the capsular bag itself. So this is a minimally invasive surgery and has advantages like no risk of lens matter falling into the vitreous, and the capsular bag remains intact till complete aspiration is done. So in this patient, 2 MVR entries are made, then the aphakic area is filled with viscoelastic, AC is formed with air, anterior capsule is stained with trypan blue dye, the dye is washed and AC is formed with viscoelastic. 2 small anterior capsule openings 1.5 to 2 mm in size are made with MVR blade and whenever possible are converted into small circular rexes using forceps. Following this, gentle hydrodissection is done through both the openings. Then bimanual irrigation aspiration is performed. It is important to follow the principles of low pressure and low flow surgery similar to posterior polar cataract. The bottle height should be around 50 to 60. The vacuum should be 150 to 200 and the aspiration flow rate 15 to 20. Gentle aspiration of lens matter is done without causing any traction on the capsular bag. At this stage, the irrigation cannula helps to support the capsular bag as well as hydrates the lens matter, aiding in its easy removal. When half of the lens is aspirated, then hands should be exchanged for complete lens aspiration. As you can see, the bag is completely intact. It is formed with viscoelastic and then the bag can be safely removed using a vitrectomy cutter. Following this, anterior vitrectomy is done. Pupil is constricted with pilocarpine and AC is formed with air. Uniformly round pupil at this stage confirms that there is no vitreous in the anterior chamber. Peripheral iridectomy is done. The wounds are then sutured with 10O monofilament nylon. The patient is rehabilitated with aphakic glasses on day 1 and is planned for scleral fixated IOL at a later stage. This technique is a safe, effective and simple. It allows complete lens aspiration Even in extreme subluxation under direct visualization, peripherally displaced lens makes capsulorhexis and lens aspiration difficult. However, with this technique, irrigation cannula helps to center the capsular bag, allowing better visibility and complete aspiration. The anterior chamber is well maintained throughout the procedure. There is no risk of lens matter drop. Thus, this technique is specially used for anterior segment surgeons to perform the lens aspiration safely in subluxated lenses. Thank you.
Yeah, it was a wonderful, innovative approach. Dr. Gopal Raju, sir, your comments?
Yeah, mainly you said that last word. As an anterior segment surgeon, you want to approach like this. Otherwise, if you hand it over to a retinal surgeon, pars plana lensectomy, they would have done it with much less openings and other disturbance to the other structures. Yeah, that's the main advantage. If you are an anterior segment surgeon, if you don't have not familiar with the pars plana ports or the vitrectomy machine and other things, so that is the main advantage. Deepali?
Yes, sir.
So as an anterior segment surgeon, so you are still in our boundaries, so you are not crossing the pars plana route.
Yes.
Right?
Yeah.
Yeah. Otherwise, these lenses with such kind of an ectopia lentis, so easily they'll come out once if you open without much risk of the rupture. These lenses will come out very easily.
The only thing is that lens cortical matter drop is not there into the vitreous, so there are very less chances of operative inflammation or retained cortical matter.
And doing a small rhexis after making 2 punctures is also that easy. I think it's very challenging.
Yes, sir.
And then the next issue is when you are aspirating and then irrigating with the other port. So keeping that fluid inside the bag and then maintaining the integrity of the bag is also very challenging. I don't know how successful you will be in, suppose if you attempt in 5-6 cases, how many cases you will be successful in completing with the intact rhexis and then the intact bag.
Yes, sir. It's a difficult technique, but actually in our residency, we were doing that routinely. So our consultant and our teachers were in the favor of this technique. So we have also published, Dr. Rajesh Sinha has published this technique long time back for subluxated lenses in the name of endocapsular lens aspiration. So we were routinely doing it at in our residency, as well as our teachers were in favor of it. So
what was the age of the patient?
6-year-old, sir. 6-year-old. Bilateral subluxation was there, so we left the patient aphakic initially, and then secondary SFIL implantation was planned.
Okay.
Dr. Karan, would you like to add any points?
Excellent surgery. How many of you have a question to the panel? Suppose it was slightly elder, about an 8-year-old or something. How many would you try to save the bag here? Would anybody have tried fixation of the bag in such situations?
I would have attempted it.
Yeah, so I would have probably, if slightly elder group or something, if I would have managed the rhexis, I would have used capsular hooks and iris hooks and tried to get it because the bag looked quite distensible. If it wasn't possible, I would have just done an ICC at this. But excellent, Dr. Dipali. It shows great skill.
Thank you so much.
Any other panelists would like to add anything? Dr. Suvira?
No, she's not there.
Nikunj deals with a lot of subluxated lenses. Nikunj, any comment?
Yeah, Karan, I would have just given a try. I mean, just like you said, if at all you are managed to even initiate the rhexis partially, and then you can use either capsular hooks to make the lens a little bit central and give a partial support, and then complete the rhexis, and then you can put a MH segment temporarily fixed with an iris hook, which I think you have also shown once. finish of the surgery, and then you can actually suture it to the sclera at the later time after the, and then implant the IOL. So that's like first stabilize the bag, then finish the cortex, the lens aspiration, then centralize the bag, and then implant the IOL. I mean, it's not easy to do. It's not always achievable, but yeah, try can be given with all. And in such cases, it is always important to explain the patient there is always a backup plan of SFI in such cases.
Any other panelists would like to add any point, Dr. KP or?
I think this duel or contest or debate continues. There are people who want to save the bag at any cost and people who would like to take it away easily and try to an SFIOL. I think it is not the question of getting it right on the table. It's a long term, especially a child like 6 or 8 years. It is also the long term plan. What are the long term prospects of the stability of the bag? What about the tilt? What about the other things that may be associated with or do? I mean, trying to save the bag. At the same time, there is also a overkill with all the retina ret surgeons trying to do now scleral fixation by various techniques. There's an overkill of trying to take the bag out as quickly as they can do an SFI. Well, that is also there. We anterior segment are trying to hold for, trying to retain the bag with hooks, rings, and trying to, hitch it up to the sclera. I think we need to find the middle path. What is suitable for the patient's long-term visual stability and rehabilitation should be the way to go. I think very well done, Dr. Deepali.
Thank you so much. But I think Sioni and ring fixation has a lot of, chances of IOL decentration at a later stage, especially if we're doing children with a progressive subluxation. So later on, there will be more chances of IOL decentration and PCO happening. So that's why.
So I think this is never-ending.
Every technique has detractors, every technique has supporters. Only thing is you need to take the patient's long-term view as the only criteria. I think each has its own plus and minus.
Right.
Dr. Deepali, why wasn't the IOL put in the same surgery rather than planning for a secondary surgery?
Actually, in case
SFIOL
of children, we wanted to minimize the GA time. So we were routinely doing a second stage surgery after a period of 8 weeks for SFIOL. And because of hypotony also and the manipulation of SFIOL was not easy in the primary setting.
I think with this, we come to the end of this symposium. And we had wonderful videos from the young ophthalmologists there. I think they are, just for the name's sake, they are young, but they are very experienced surgeons. They are very meticulous surgeons. We could see from their skills. And thank you so much, YOSI, once again for collaborating with IIRSI. We really had a wonderful session. And we can't thank our panelists enough, Dr. Krishna Prasad, Dr. Gopal Raju, Dr. Suvira, Dr. Sonal, Dr. Karan, Dr. Divakant, I think couldn't join, Dr. Nikunj for giving wonderful inputs and sharing their experience also. And of course, Dr. Vardhaman.
We have Dr. Himanshu Mehta, the boss, also here.
Oh, the big boss from Mumbai. Welcome, Dr. Himanshu.
Welcome, sir.
How are you, sir?
I think, yeah, great to see you, sir.
Great to see you.
So I think without wasting any time, let's go for polling. As we promised, we'll have online polling for best 3 videos, and they'll be given away the prizes. So Mr. Sunil, are we ready for the polling?
Yes,
I'll request everybody to use this polling, and first option will be for first position. So you have to choose. Yes. Yeah, tell me, Mr. Sunil.
It's first, second, and third, right? The sequence first position.
Yes.
Okay, sir.
First, second, and third. So first poll, when the first poll comes, all the 8 names will flash. So you need to select the person you think today gave you the best video. A lot of polls in there for you. So Mr. Sunil, can you have the first?
Yeah, launching it on the screen. It should be there for like 20 seconds. Please only comment, don't comment anything. Just use the exercise option of selecting the name who you think deserves the first position, and do not write anything in the chat or on the screen.
Everybody on Zoom panel, including judges, panelists, everybody will use this, right?
Launching it now, please. It's on the screen. Closing it in 5 seconds. Closing now.
All right.
Can you share the result? Okay. So everybody can see the result?
Yes.
So
Yes.
on first position, we have Dr. Anu June.
Can I stop,
He
sir?
got 41% of the votes. Congratulations, Dr. Anu.
Thank you so much, sir.
Should I launch the second, sir?
Yes. So now you need to select for second position. You don't have to select Dr. Anu in this. Please, Mr. Sunil.
20 seconds, please. This is a tough one. Closing in 5 seconds, please. Closing now. I mean, there is a saying, Houston, we have a problem.
Are we done?
Yes, sir.
Okay.
These are
Everybody
the
can see the results. So on second position,
Yes, sir.
we have Dr. Rohan Mehra, who has got 32% of the votes. Congratulations, Dr. Rohan. Okay.
Thank you. Thank you,
Now
sir.
for the third position, can you share it again?
Please don't wait for Dr. Anu and Dr. Rohan.
Five more seconds, please. Closing.
Wow.
Okay. So we have on third position Dr. Deepali Singhal with 31% of the votes. Congratulations, Dr. Deepali.
Thank you.
Congratulations, Deepali.
Okay. Yes. Yes, Vardman.
Yeah, both I think Dr. Aarti and Dr. Saiban were very close, cut to cut, almost making it. But I think all the presentations were amazing. I think all of them
Amazing.
amazing dexterity, presence of mind, a lot of learning pearls. And I think, as you said, although they are young ophthalmologists, but the skills are like veteran surgeons already. So I think very well trained set of surgeons. Very nice presentations today. Yes, absolutely.
So
Thank you
I'll
all.
just request our panelists, Dr. Gopal Raju and Dr. Krishna Prasad, to say a few words before Dr. Karan with his vote of thanks. Dr. Gopal?
Yeah. That was excellent videos from all the ophthalmologists. They really they mastered the techniques, and not only the standard techniques, they have innovated very well. All the best, and then keep improving. Thank you very much for giving this opportunity. Bye-bye.
Thank you, sir. Dr. KP?
I've been a trainer for surgery for my postgraduates. I think every mistake made is a teaching opportunity. Always feel free to share your mistakes, share the suboptimal outcomes, because the other surgeons, so-called the seniors, would have gone through the same pace. There's no point learning about something, making your own mistake. Learning from seniors, mentors, and learning from others' mistake is the way in surgery. You don't have to really sacrifice too many eyes to become the master. So always, and also have any such case, You always try to see what others have done and try to see can it be done better. I always believe that there's always a better way of doing everything. There is always a simpler way of doing everything. Just believe that and go out. Thank you so much.
Thank you very much. And I'll request Dr. Karan to say a vote of thanks before we say goodbye.
Thank you to IIRSI, Harshul sir, Vardhaman sir, for having us here. A big thank you to all the panelists. My guru, that is Krishna Prasad sir, was here also here. Gopala Raju sir, Suvira madam, and the other panelists, Sonal, Devakant, who couldn't join, Nikunj from YOSI. Excellent. The presenters have done an excellent job, and it's not easy, particularly showing all the mistakes that you have made. I would echo all the words that the seniors have said. A big thanks to NTOD as well for being a very important partner in this competition. Thank you so much.
Thank you, Zen, for moderating so nicely and helping out in
Thank you, sir.
all
Thank
planning.
you. Thank you for
Dr.
including me.
Vardhaman and Mr. Sunil for taking care of all the IT part, and to Entrod Pharma. Thank you so much, everybody, and
thank you.
Bye-bye.
Bye.
Bye-bye.
Thank you.